Nitin Kapur works at the Queensland Children's Hospital as a respiratory and sleep paediatrician, and he's also the Director of Paediatric Education and Director of Clinical Training at the QCH. He is the President, of course, of the Paediatric and Child Health Division of the RACP. He likes to play tennis, and his name, he points out, is a palindrome. If you're writing it down backwards and you're getting it mixed up, don't worry, it'll all turn out okay in the end.
That's right, and I'm going to start with the longest palindrome visit, which is, was it a car or a cat I saw? So you'll figure it out for that. So thank you for inviting me to this talk. Most of what I'm going to talk today is actually pertaining to my role as the Director of Pediatric Education. And while the topic is healthcare change, I would focus on trainee change. I'm going to start with a clip from a Being Human podcast, thanks to the pomegranate of the RACP. So it's a couple of minutes long, and then we'll go into the talk.
One of the most traumatic events of my life occurred at a country hospital on an Easter. I was in my first term of my second year, so I've been a doctor for 13 months. This hospital, being on the highway, every now and again has massive, horrible accidents. They had a massive, horrible accident, and I was the doctor for the hospital. It was absolute bedlam. It was like being in a war zone. Even now I think about it, I think I want to cry. I saw people die who shouldn't have died because I didn't have the skills, or the one that still makes me. The little 2-year-old came in still in the car seat with an obvious fractured head. It was like being in a war zone. One of them had a hole in their lung, and the lung was basically compressed and they couldn't breathe. And I'm thinking, where is everybody? The specialists are still at home waiting for the second phone call, and of course I'm drowning in blood. I think looking back, I did the best job I possibly could, but I felt, of course, responsible. It was absolute hell. Amongst all of this, I never got relief. Literally, the whole of Easter. My body starts shutting down. I start throwing up. On the Tuesday, so medical admin opens up again. By this stage, I'm going, where is the other doctor? I'm ringing up and they go, oh, she's not coming back. I said to them, patients are at risk because I am just traumatised beyond belief. I haven't slept. I haven't eaten. I'm just not functioning, and you need to do something for the sake of the patients, not necessarily me. I got no support at all from that. The point of the story is then when you come back in again to apply for your job the next year, you come in for an interview, and there was a very intimidating long table with 5 very high-level doctors at the table. You're a little bit anxious when you're walking in that door. Before I even crossed to the table where the seat was, one of them said to me, so you're that whinger from the country hospital.
So it is a confronting situation, something that probably all of us have been in some part of our trainee life. Today I'm going to talk about burnout in healthcare workers. It is well known that we work in a we are high-functioning people working in a high-stress job. Out of all of you here, in a recent survey, nearly 50% of us will fulfill the criteria of stress, will fulfill the criteria of high stress. While stress is response to an external force, distress is not acceptable. A lot of us are actually distressed. 20% of us, 1 in 5, are actually thinking of leaving a profession. We are tired, we've had enough. 1 in 5 of us have had depression in the last 2 years. In fact, 6% of us are currently struggling with depression. And this goes on. There has been high incidence of thoughts of suicide. 1 in 4 have considered suicide in the last 2 years. And in fact, there are figures that say that that's gone up to 50% in the last 2 years with COVID. And even worse, 2%, I suppose we are at least more than 100, 150 here. 2 or 3 of us in this audience have actually attempted suicide. These are very confronting figures, which are much more prevalent in the medical profession, in the healthcare profession, compared to non-medical profession. And one of the examples that the podcast highlighted was the moral injury that the trainees go through when they are not able to fulfill what they perceive is the requirement from them or what's expected for them. Very confronting indeed. Why are we at risk? I actually bring to an article that I read earlier in the year at the Sydney Morning Herald, where it was clear that distressed doctors, they don't bend, they actually break. And why they don't bend is because they're self-critical. They have high expectations from themselves. They don't ask for help soon enough. This sense of loss of control, medicine is one of the few professions where the junior doctor or the trainee doesn't know who walks into the ED, which kind of patient, what their day will entail. They probably have loss of autonomy, they have loss of control over their roster, over their weekend work, what hours they're going to work. And this loss of control obviously leads to loss of meaning. Our junior doctors feel that they have lost control and meaning in their job as well. With this, giving away again and again forever leads to compassion fatigue, a term commonly used, but it's a real thing. We have to be compassionate at work, and when we keep doing that, it reflects in what we do at home, in our personal life. We've already spoken about the moral injury, which all of us go through when the system does not help what we're trying to achieve. And then we are self-critical. And what is the result of doctor burnout? We all know that there was a recent survey in the surgical and the medical college as well, and 1 in 10 trainees felt that they have done a major medical error in their profession in the last 12 months. So they always, and obviously that's a reflection of their fatigue, their burnout as well. And if you're not performing well in your work, it reflects on patient satisfaction. When the patient is not satisfied, you're further self-critical, leads to further burnout. And I believe that there is a snowballing effect. Having worked recently as the DPE, the snowballing effect of burnout was most obvious during COVID. As more and more junior doctors were struggling, sick leave increased. Those who were coming to work had to work longer hours. They were more fatigued, there was more burnout, and the snowballing effect did not end. So hence, COVID was a clear example. And if you haven't read yet, I encourage you all to read this book from a trainee, Yumiko Kadota, who was a surgical trainee, who talks about this toxic culture in training, the bullying that she faced, and definitely comes up with some solutions around that. A statement that I quite liked was that she was choosing knife over life. And that's something that stayed with me. But I'm not here trying to tell you a sob story about trainees. I was attending, so my daughter is in grade 6, she's going to grade 7, and while I was thinking about what I will talk about today, one of the school principals got up about how to support my daughter in high school, and she said there's the famous African proverb that you should not try to make the road fit for your child, but try to make the child fit for the road. And I am not going to talk about making the trainee fit for the road. I am here to talk about how to make the road fit for the trainee, how to make the road, the system suitable that the trainee's fatigue and burnout is not there. I'm not here to talk about recharge strategies. I'm here to talk about prevention discharge. I'm not talking about yoga apps. I'm not talking about meditation. I'm not talking about self-realization. I'm not talking about mindfulness. Because I believe that burnout is not a mental health illness. I firmly believe that burnout is an occupational disease. When the problem is at the workplace, when the problem is occupational, the solution has to be at the workplace as well. And we all here are leaders in some way, shape, or form. We need to make change happen at the workplace. Because when you put it on the trainee, in some way it implies that the doctor is weak. And that's not the case. Our doctors, our trainees are not weak. It's the system that's at fault. So roughly, again, in preparation of this talk, I tried to speak to a lot of trainees. I did not want to send another survey because there's already a big survey fatigue. What do the trainees want? The trainees want job security. They do not want repeated applications every year trying to find terms. They want flexible training options. The trainees request quality, protected, flexible training. They want consistency in supervision. They want support in supervision as well. And then they want adequate leave allocation. They need and they request a bit of autonomy. And most important, they want that they should be listened to. So before this talk, I do not want to grow up. I was speaking to Ben Lawton, and I do not want to grow up into a 65-year-old cynical doctor. I want to make change, hence this position that I am in. So I'm going to talk about what's already been done in the network model of training. I'm going to talk about flexible training and educational initiatives that have been done, and how, as the DPE in Queensland, as the college president, we're trying to support protected teaching, virtual education, teleclinics. And as a responsible education provider, we will also discuss how training has changed in terms of gender equity, supporting diversity in training, and supporting the rural needs. So one thing at a time. First of all, I'm going to talk about the network model of training. And I'm told that Dr. David Levitt will be in this conference at 12:30. For those who don't know David, David is the Director of General Pediatrics, who is currently on leave. David, Dr. Alan Siv, who I see as one of my mentors, and I got together many years back and decided and came up with why trainees are struggling with job applications. We started the Queensland Basic Pediatric Training Network. The network basically gives job security. Once you enter the network, it has got a designated path for you for the next 3, 4, 5 years, howsoever long you want to take. It'll fulfill all your basic training requirements. And I believe that it was a huge success. We then extrapolated this success to the Queensland Advanced Training Network as well. And now there is a neonatal network as well. And RACP, the college, our college, obviously liked the Queensland way of training, and they have incorporated nearly all of the Queensland way of basic pediatric training into a country or a bi-nation-wide program that they're trying to launch. So the advantage of the network are plenty. There's certainly job security. You do not need to apply every year. Your terms are pretty much well taken care of. There is a decentralized model of recruitment. Now, a trainee is not dependent on the whims and fancies of the DPE or the biases of the DPE. There's a proper selection system. There's a transplant system. And I believe that is a much better system. And I certainly believe that the trainees feel supported. And while I do not have exact figures from 12 years back, when I sat the exam in 2010, at least in pediatric training, the model was that most female trainees will finish their basic training, get into advanced training, and then probably start a family in advanced training. That was the model when I saw it. And over the last 10 years, I feel the basic trainees feel so supported that we have lots of maternity leave in basic training, which is a great thing. And I think that's a reflection of trainings having job security, feeling supported as well. And 15% of our current basic trainees on the network have been supported with maternity leave in the 5 years where this network has started. And 1 in 5 trainees actually take longer. This is not the exam, so we remove those who were not successful with the exam. Outside of that, 20% of trainees have actually taken longer than 3 years to complete their basic training, which I absolutely see as a good sign because there is an ability to work part-time. And then there is no real pressure to sit the exam in year 3 because there is a sure job for another year. So I am very proud of the network model that has worked in Queensland really well. Going on to flexible training, this is an unmet need of all trainees. Ability to work, reduce hours, it's difficult. And we had taken it upon ourselves to try to have as many part-time worker or junior doctors as possible. Now, there's always will be a debate between college versus the administration. You have to believe me that the college does have adequate provisions to support part-time work. But the issue becomes at the hospital level, and I am not talking about job share where the trainee is responsible for finding the job share. I'm talking about standalone part-time jobs which are advertised as part-time jobs. I know places like ED have done well, but subspecialties and big hospitals like QCH, which has ward-based training, it's still very difficult to have standalone part-time jobs. Again, speaking for the QCH example, the numbers of job shared positions have incrementally increased every year. It was 10 2 years back, 12 and 14 this year, and it will be 16 for next year. But the aim is to have such flexibility that the trainee can virtually work during school hours. And I'll talk about my vision. While I do believe vision is important, I also believe that vision without execution is hallucination. So we need to have actionable steps. I can stand here and talk about all the fluffy bit, but I'm not going to only talk about the fluffy bit. The flexible training, we have tried to make action happen in flexible training. In Australia, the rural requirement can be done in either basic training or advanced training. So a bit of flexibility. The assessment requirement is being reduced for people who want to work part-time. We are, and I assure you in my role as that, I am going to use the accreditation stick to make sure that every small hospital has standalone part-time work available. And exam more than once. This buffer recruitment, specifically at QCH, I want to give you some figures. For 96 registrar positions, our executive is so supportive that we actually offer 118 registrar jobs for 96 registrar positions because we need to have that buffer. So the problem is because we do not offer part-time work, people say yes to full-time work at the beginning. As soon as the first term ends, they want to work part-time. And hence, this buffer rarely works at QCH. And there are certainly other college initiatives that have supported part-time work. We've got College Learning Series. For those who haven't seen it, this is a big repository of lectures, now 80. I actually encourage you to go and have a look. We in Queensland had the pediatric written exam preparation program, which is an after-hours online teaching program so that the trainees can attend these lectures at their convenience. As the college president, I would make sure that the advanced training projects are made easier. There is statistical support available to all trainees paid by the college. And more recently, the professional development leave that the trainees were taking will not be subtracted from the training time. It is actually feels common sense, right? But it was not the case up till so far. We are definitely encouraging virtual training as well. While I am not endorsing any of the sponsors here, but Cub Care I saw outside, they are actually trying to have an online-only training position for the registrar. And that's the way to go. We will have positions where the trainee can actually work from home, and that can still be counted into the training program. Again, I have rarely canvassed for protected teaching time, and my understanding of protected teaching was that if a trainee is going to teaching, someone holds his or her phone. I was having coffee with my current junior doctors, trying to discuss this talk, and I asked what is their understanding of protected teaching. I was surprised when they said that protected doesn't mean just someone holds the phone, which is an administrative officer, because when they come back from 2 hours of protected teaching, they have to answer those 40 phones. Protected time means that the phone or the pager is being held by someone who's doing the work for them, and preferably a consultant or a senior doctor. There is significant disagreement between the senior consultant staff if they are ready to hold the junior doctor's phone. But this needs to change, and we are changing it. There is always this issue, and I want to be a little bit provocative here about overtime for protected teaching. Should the trainee who comes from home to have a protected teaching time be paid overtime? And I do not have an answer to that. I think there's a difference of opinion, but maybe a point of discussion at the end. And with that, we have to have a supportive supervisor. There needs to be consistency in supervision. all supervisors need to have some kind of training so that we can preach role modeling, goal setting, good feedback session, and empathy. And at the college, we've done that well with the SPDP program. This is an interesting fact only because I feel that pediatric needs to lead by example. More than 80% of our current trainees are females, and this is increasing. So we have to be the role model in training for supportive training. And I might just skip that in the interest of time. We have supported lots of HC initiatives. We have a PCHD work plan as well, and we have diversity in selection panel as well. Still, lot still needs to be done. We need to have standalone part-time position. Job share is okay, but standalone job time should be there. We need to have some agreement on what protected teaching time is. We need to have accreditation of virtual-only terms so that work from home is a reality. And certainly, this school hour training has to be done in pediatrics, and Henry would remember a session that we had with a distressed trainee where the feedback from the trainee was the dislike for this hierarchical model of training. Supervision is a two-way field. The supervisors also have a lot to learn from the fact that they are supervising. So to conclude, burnout is not a mental health issue. It's an occupational disease. But in all honesty, positive change is happening in pediatric training and probably in adult training as well. Cultural change has started. In the last 10 years in my DPE role, I have seen change happen, but a lot needs to be done. And we are not asking for too much, to be honest. The next video will tell you that we get happy with very little.
Hey, how was your weekend? Oh, it was awesome. I had a golden weekend. I got a lot of stuff done. Golden weekend? What does that mean? Oh, it just means I had the whole weekend off. Oh, okay, like a 3-day weekend. Oh, no, I worked on Friday, but I had Saturday and Sunday off. So you just had a weekend off? Yeah, but I had both days off, Saturday and Sunday. Okay, that's just a normal weekend off. Yeah, but it was a golden weekend, so I got to leave Friday afternoon. I didn't have to come back to work till Monday morning. And that's exciting to you? Well, yeah, it's 2 full days off. So you got a college degree, and then you went to med school for 4 years to get another degree. Yeah, that's right. So after years of advanced education and training, you are now at the point where you're just excited to have 2 consecutive days off. Yes.
Thank you very much.
Nitin, thank you so much as well. Look, we've concentrated a lot on the positive things you put in place, so thank you so much also on behalf of your trainees. Just a reminder that we've dipped into some dark topics at the start as we've reflected on burnout. If anybody is feeling like you want to reach out, please do. But again, thanks, Nitin. Do you have a question, Eve, that's come through?
Yeah, so there's a couple of questions, a lot of appreciation for this work, but I suppose some practical questions that are relevant to pediatrics, but also potentially some other training programs. With some of the very real issues that organizations are facing with understaffing, particularly in rural and regional areas, how does this vision happen?
Yes. So again, going back to the model that we have incorporated with the network, we certainly for selection give extra points based on those who are from rural background, because there are statistics that say that people who come from rural background into training tend to go back to the rural background. Certainly at Passover network, 12 months for each trainee has to be outside the big hospital. 50% of them spend time in rural and remote areas. Same with advanced training as well. Out of the 2-year advanced training program, at least 6 months are spent in a rural area. So that's our bit that we are trying to do to support the rural training as well. I do understand in a smaller center, a secondment hospital, part-time work is very hard, let alone so job share is very hard, let alone a part-time work. And the way of the future is that the central hub, which will be the tertiary hospital, do need to backfill any requirement at these rural and remote. That does involve movement, and certainly it's not easy for trainees to have that movement. Those are the steps that I feel we have done or taken to support the rural workforce. This is real. COVID-related absences is real. The grand rounds that I had tweeted a photograph of the grand round. Nelson was talking about cardiac surgery. There were only 4 people in the audience. That is the real reflection of how things have been because of COVID-related leave and issues. And hopefully things will get better.
Thank you so much, Nitin.